Happy Tuesday. Welcome to Behavioral Health Echo, everyone. My name is Summer. I'll be your coordinator for today, along with Dr. Withy, our co-lead and director for Behavioral Health Echo. Today, we are happy to have Dr. Sneed and Brianna Fitchett return from Catalyte, and they'll be talking today about applied behavior analytics therapy and what exactly that is. Without further ado, I will stop sharing my screen and hand it over to them. Thank you both for coming back to share with us.
Yeah, we're excited to
Absolutely.
be here.
Thanks for having us again.
Okay. And Brianna, you see the right slide, yeah?
Yes,
Okay, great.
we
Okay.
are good to go. All right, perfect. So let's dive right into what exactly is applied behavior analysis. This is us. Although of course you can see us here on Zoom as well. We have both been with Catalyte. I think Lindsey's been with the organization 11 years and I'm just behind her at 10 and a half years. So a little bit about Catalyte and our organization. We serve over 12,000 participants or patients and their families every day. We're also partnered with our affiliates, Easter Seals. So we have Easter Seals Hawaii and Easter Seals Northern California. Lindsey and I have worked extensively with both of those affiliates before moving over to the Catalyte side. And then we also have Zolve, which is a technology organization that we partner with. As you can see, we've got a good number of providers. So those are organizations that we work with, as well as practitioners and employees. And then just a little bit about us and our core values are bold, community-centered, equity-informed, and well-being driven. So everything we do really leans into those values, and we try to exemplify those in everything that we do. So today our goal is to walk you, or excuse me, I can't talk. Today our goal is for you to walk away with a deeper understanding of applied behavior analysis, or ABA, the outcomes of ABA and various ways that it can be implemented to fit a family's or a patient's individual needs. So these are our learning objectives. I'm not going to read through them, but the goal is that you can walk away with these three kind of areas under your belt. All right, Lindsey, I think this
Sorry, I muted myself right as I was
We have a quick question. What is the difference between a provider and a practitioner?
That is a great question. And I think it's probably one of the things we explain the most. So a provider in our world is an organization. So we've got 100 kind of independently owned, operated businesses, organizations that are in our network that we work with. And then a practitioner is a person. So a clinician, a paraprofessional, a physician, someone, an actual person.
Perfect. Okay. So we thought it'd be helpful if we went through a brief history of applied behavior analysis and how it became an intervention that it is today. So first, it really started in the early 1900s, specifically it became its own theory of psychology in 1913 when John Watson, a psychologist, wrote this letter to psychologists saying, you know, we can't just do psychoanalytics anymore. That's not enough. We need to be looking at behavior measurement. So it was soon after that Ivan Pavlov came along, and we have Pavlov's dog, right? When we started to learn more about reflexive responses, and how we have these behaviors that are innate that occur when we see or are about to eat something that we really like, we start salivating. When we feel hungry, we want to eat, all those kinds of things. So we have some early starts of behavioral theory. And then from there, it became more formalized with operant conditioning, which is a lot of what applied behavior analysis today has come from. And that came out of B.F. Skinner's work. And so he really was looking at reinforcement and punishment. Like, how do we increase behaviors that we want to see more of? And how do we decrease behaviors that we want to see less of? So out of operant conditioning, behavior modification became like really big a lot in school systems. We saw a lot of behavior modification. It was also around this time that cognitive behavior therapy, which is like a branch of behavioral therapy, started its own direction of psychology. So from operant conditioning behavior modification, we have cognitive behavior therapy, or CBT, and then also ABA, which is what we see today, became more distinct itself. So both ABA and CBT came out of the like behavior modification. But with that, ABA started becoming its own distinct field, really in, like more solidified in the 60s, with Wolf and Risley really talking about the research that they've been doing. And they started teaching more individuals with developmental disabilities new skills. And then we had more early applications in the 70s and 80s. Again, a lot more expanding into school systems, supporting individuals in the school systems, and even in like residential homes and things like that then. And then in 1980s, Ivar Lovaas did a landmark study showing that for some children with autism, applied behavior analysis can be a very effective tool to gain new skills. And we're going to talk a little bit more about that in a little bit. And from there, from the time of Lovaas, like that's when families really started advocating, say, hey, we need more services for our autistic children. What can be offered to our kids? We're seeing this study by Lovaas showing that it's really effective, this ABA thing, whatever it is. We don't know what it is, but we know that we potentially want it for our children. So in the 90s is really when ABA began to like get more notoriety, more understanding, more and more families were wanting applied behavior analysis. And then what happened in the 2000s is insurance companies, there was laws passed that said that insurance companies had to cover behavioral treatment for autistic people. So from there, ABA has continued to grow because ABA is is an evidence-based intervention for people with developmental disabilities. I want to say it's not the only treatment, but is a treatment. And we're going to talk about new ways that ABA can be implemented that might be more family-friendly or better for the individual. So that's just a brief history. Some basic principles that come along under the guise of applied behavior or under the realm of applied behavior analysis is like behavior. So when we're talking about applied behavior analysis, usually when we're talking about behavior, we're talking about anything that a person does or can do or is doing. So anything that can be observed by another individual. So all you right now are observing me engaging in a lot of different behaviors. I'm talking, I'm moving my hands, I'm shaking my head. All those are behaviors. So we're talking about behavior more writ large, not necessarily negative or positive behaviors. Then we have the ABC model, which helps us understand behavior, why it happens, when it happens. A standing for the antecedent, or what happens right before a behavior. B is the behavior. And then the consequence stands for like what happens right after a behavior happens, which leads us into reinforcement and punishment, which we don't need to go into all these specific details, but these core principles here are really going to be part and parcel to any ABA program. We're going to be reinforcing behaviors that we want to see more of. Probably not a lot of punishment going on anymore. Maybe extinction models where extinction just means that we're no longer providing reinforcement for a previously reinforced behavior. Trying to generalize skills. So when we teach skills to individuals, we don't just want to teach those skills in a vacuum. We want to be able for individuals to take the skills that they learn in one setting or with one person or with one item and be able to apply those same learnings to other people, to different settings, and to different items. So we have the basic principles of applied behavior analysis, which are used very largely in the field of psychology in general. So these aren't like specific to applied behavior analysis. But when you're getting intervention that is based on applied behavior analysis, you're definitely going to see these areas as part of the intervention. So is ABA treatment? So ABA in and of itself is not a treatment. It is a way in which we understand behavior. So we can reliably look at antecedents and consequences and understand how behaviors are impacted. So while ABA in and of itself is not a treatment, interventions based in applied behavior analysis are considered evidence-based treatments. So we are really trying to understand why behaviors happen, how skills are learned. And this interventions based in applied behavior analysis can happen in many different formats. It can happen in a parent-mediated format, in a caregiver training format, and it can occur in a group home where they have a behaviorist who works in the group home to support the individuals. It can occur if you've heard of naturalistic developmental behavior interventions, or NDBIs. So NDBIs really take into account the principles of applied behavior analysis, but mapping them onto developmentally what's appropriate for individuals. And just again, to reiterate that ABA can be implemented effectively in a lot of different ways. There isn't just one way to implement it. So I kind of touched on this briefly, but we see like the general models of applied behavior analysis interventions are parent-mediated interventions, tiered interventions, or consultant or direct-to-client interventions. So in parent-mediated interventions, what happens is the behaviorist, either a behavioral psychologist, maybe board-certified behavior analyst, work directly with the parents to learn the skills that they need to learn in order to teach their child new skills. This is a very, very effective way to implement applied behavior analysis procedures that benefits both the parent and the child. Then we have our tiered implementation, which is really one of the most common ways that applied behavior analysis is implemented, where a paraprofessional is taught how to implement applied behavior analysis procedures, and that paraprofessional works directly with the client with training and oversight by the behaviorist. And then we have that consultation or direct-to-client model, which is where, like you might see in school systems or like in group homes, where you have a behavior analyst or behaviorist coming in, training individuals on how to work with a particular group or individual. And then at Catalate, we launched a new consultation model last year called Compass B, where our behavior analysts work directly with the autistic patient themselves. And it looks and feels a little bit more like a therapy setting, but it's not therapy. It's really learning behavioral procedures that the individual can implement themselves on their own behavior. And this is typically with youth or adults who have level 1 autism spectrum disorder, who don't have a co-occurring cognitive ability, or cognitive disability, but it is another way that applied behavior analysis can be implemented effectively. So there's been a long-held belief, and we get this question a lot, that applied behavior analysis requires a lot of hours. And frankly, we just consistently see in the research that hours are not predictive of positive treatment outcome. So a lot of studies have been done demonstrating that there are really important factors that can tell us what are going to be good predictors of positive outcome for applied behavior analysis. And I'll get to this one in a second, but the Rogers study that I'm about to talk about was very, very influential in the field. So in 1987, Lovaas did that landmark study. And in that study, we had 30 to 40 hours a week that the children received, because at that time there wasn't we didn't know what was going to be best, and it was like a school setting. It was like they were in a classroom for 30 to 40 hours, which is pretty typical. And we used that into the 80s and 90s and early 2000s to be what established, okay, this is the information we have about this intervention that's super effective. And since the original study did 30 to 40 hours, we're going to go ahead and be implementing 30 to 40 hours because that's the best available evidence, right? And when we look at evidence-based practice, we look at the best available evidence, what the clinician is trained in, and what the individual who's receiving the services wants, or what's like high desirability to them. So based on evidence-based practice, we use that original study to inform our practice. But since then, as this was like almost 40 years ago now, there's been a lot of research done on hours. What is needed to make a really big impact? So in 2007, these researchers, Reed and colleagues, conducted a study, and they were comparing a low-hour group to a high-hour group. So the high-hour group was receiving about 40 hours a week. The low-hour group was receiving about 10 hours a week of applied behavior analysis in that paraprofessional model, where paraprofessionals coming into the individual's home, or they're going to a clinic and working directly with an individual. And while they did find that the group that had more hours actually did do better, what they also found is that all the clients, or the clients who had over 40 hours, or who had 40 hours per week, had diminishing returns on over 20 hours per week. So that was kind of our first clue of like, oh, diminishing returns over 20 hours. Like, you know, what is the best? We've been asking, like, what is the best dosage then? Like, what should we be doing with our families? So then in 2015, Tristram Smith and his colleagues, they conducted a study. They were specifically wanting to understand what are predictors of positive treatment outcome for young autistic children. And in their study, they found baseline social skills and intellectual ability to be the best predictor of treatment outcome. And while hours was included in their model, hours did not hold up as a predictor at all. And Tristram Smith, who was in the field for a long, long time, they concluded in their article that despite the long-held belief that hours was associated with better outcomes for autistic children, that actually may not be true. So then Rogers and colleagues, they conducted a study in 2021, and they were comparing a 15-hour-a-week group to a 25-hour-a-week group, receiving either an NDBI, a naturalistic developmental behavior intervention, or a more formal ABA program, which is based on discrete trial training. And this is one of the very, very few randomized clinical trials in the field of applied behavior analysis. And it was a randomized clinical trial that was done across multiple sites. And what they found in their study was that all groups actually had equivalent outcomes. So the group that received 15 hours a week of intervention actually did just as well as the group who received 25 hours a week of intervention. So now we're kind of seeing like what is a more appropriate amount of hours in a paraprofessional delivered model. And we are seeing that possibly no more than 15 hours per week. The DoD and Vanderbilt University are going to be coming out with a study very shortly where they actually compared about 8 hours per week to about 15 hours per week, and those were also equivalent. So we're narrowing the range on what is really most appropriate for our patients. And then we have recent meta-analyses. I could drone on about all these meta-analyses for far too long and bore you all for a really long time about them. But the good news is that what we're consistently finding is for some people with autism, applied interventions based on applied behavior analysis are really effective. And they're really effective even with a lower amount of hours, or just, I should say, just as effective as if they were to receive 20 or 15 hours or 25 or 10 hours per week. We're seeing consistent gains. So Donalou, Eckes, Wergland, Fuller, and Kaiser are all showing we're seeing all these really positive gains in interventions based on applied behavior analysis. And the good news is we don't need as many hours to do so, which ultimately for us as providers means we can actually serve more people who need services.
All right. So like Dr. Sneed was saying, applied behavior analysis really is effective. First, I think it's really important to talk about ABA, applied behavior analysis. It's not a cure-all, and it's not right for every patient or family. Like Lindsey was saying before, there are other treatments, other services that might be a better fit. There was a time when ABA kind of equated to autism. And we're really trying to move away from that to make sure that we're treating the family or the patient with what is best for them. With applied behavior analysis, some clients make progress and some do not. But it's really important to understand ABA as a treatment option, but it's not the only one. So I think it's really important to talk about, like, as we're talking about the effectiveness, to also be setting realistic expectations with families, talking with families about the expected outcomes from the get-go, having conversations with families specifically as well when they have a child that has ID, intellectual disability, as well as an autism diagnosis. We see many families come to us who might be a couple years into treatment whose child has ID, and that's never really discussed. Autism's at the forefront, ID isn't, and in these cases, it's really important to be talking about that, because when we go back to the effectiveness, ID might be the reason that learning and progress might look a little bit different for that child or that family. Lindsey and I have been talking about this with our teams, kind of, and especially to you guys as care team members, as physicians, removing that kind of taboo topic of ID, talking about it with families. We see a lot of times members of care teams kind of shying away from that conversation, which ultimately does a disservice to the patient and to the families when they are potentially having some expectations of what treatment might look like or what the effectiveness is to what it's going to be for themselves or their family. Anything else, Lindsey, that you want to add to that? No.
I just couldn't find my mute button again.
No worries.
Yeah, I think you hit the nail on the head, is that there is a large proportion, or there's a proportion of autistic individuals for whom this can be a really, really effective intervention. And one of the things I'm excited about at our work that we're doing presently is really trying to find behavioral models that are effective in different ways for different people's abilities and skills. It's going to look a little bit different, like Brianna was saying. Somebody who has autism and intellectual disability, how they're learning is going to be very different from somebody who has autism alone. What we can expect from learning, what we should be focusing on intervention is going to be different. An 8-year-old who has autism and a moderate intellectual disability, we might just want to really focus. And if let's say that they're nonverbal, so they don't have verbal skills in the way that we typically think about verbal skills, we might be focusing with that individual on what we call functional communication, or learning how to point for what they want. Pointing can be a very, very effective way to communicate to partners in the environment what they need and what they want. Whereas a 3-year-old who has autism and now not intellectual disability, it might make more sense for us to focus on verbal communication because of their neural plasticity, hasn't solidified by that point. There's a lot of potential for going into the communicative method of being able to, or the vocal method of communication. So really thinking about how can we individualize what is needed based on the presentation of the individual who is in front of us. And another thing I really like to emphasize with people is the reason for the referral. What is the referral question? Why are they coming to us? And that could look very different across the board for families. We can have a family coming in who their referral question might be that they have a teenager who has really dangerous behavior. In that situation, really what we should be focusing on is reducing the dangerous behavior and not focusing on all these other things that we think are important, but really focusing on the referral question. And I see we have a hand up.
Oh, I just wanted to read out the question. An interesting one. What about intellectual disability from too much video games and screen time? Does that impact the intellectual disability that you can tell, or is it after age 7?
So with intellectual disability, it's generally you're born with it, or there's something in early childhood that happens that leads to intellectual disability. Something like video games or screen time won't necessarily cause intellectual disability, but what it can do is too much screen time can impair your social skills, and we see that being true across the board for neurotypical and neurodiverse individuals. It can impact your social skills and frankly your mental health. So those would be things that I would be concerned about, is how's their mental health doing, particularly for preteens and teenage females. We consistently see that screen time in the sense of social media can be very, very negatively impacting. And then it's so hard. This question it's a really good question. And one thing that's really hard is video games is very common amongst youth, like typically developing youth and neurodiverse youth. And for some people, video games is how they socialize, right? They have like a social community with their video game partners. So I think it's really important, again, to be looking at what is that individual telling us? What is important to that individual? How is it impacting them? How much can we give them self-determination, which means how much can we let them have choice over what is happening versus trying to control it? So there's so many nuanced questions in there where it's well, are they engaging in video games for 10 hours a day? And they are not interacting socially at all. Their social skills are definitely going to be impacted in that scenario. But again, we have to really be looking at the individual and what's happening in that context. What are video games to them? Do they have a social community within their video gaming community? How much is it taking away from engaging in real life or adaptive skills even?
Yeah, and I'm seeing some great comments in the chat around video games. But yeah, let's see. Lindsey, do you want to just hop to the next slide real quick?
Oh yeah, I'm sorry.
No, you're fine. Kind of continuing on the same topic or same area, talking a little bit more about outcomes. So you kind of touched on this already, Lindsey, but what we see through current literature is that cognitive ability continues to be one of the biggest predictors of positive outcomes in ABA, which, like we were just talking about, it's really essential for families to understand this, and for families whose child does have an intellectual disability to understand what the role of that intellectual disability has. And also for the treatment team, like Lindsey was saying, when we're treating or when we're working with one patient with autism and ID, it's very different than if we're working with someone who just has an ASD diagnosis. So having those conversations from early on across the care team, kind of across that continuum of everyone who is supporting and working with the family, is really important. Another area that we see that is predictive of outcomes is age of entry. So, I feel like anybody who works in the autism ID realm, you'll hear them talk about, early intervention, getting into services early, because we know it does make an impact on the outcomes. The earlier that we're getting kids in is really making changes down the line. We also see that individuals with more social abilities leads to better outcomes. So, when we have clients coming in with some of those social skills or the social communication, that plays out in outcomes as well. And I see another question in here. One second. Well, I read, is ABA effective for other types of developmental delay diagnosis? And will insurance cover ABA for diagnosis other than autism? So yes, so I will probably kick this one over to you, Lindsey, but we definitely are working with clients with different diagnoses and multiple diagnoses. Do you want to add on to that?
Yeah, so that's also like, that's such a great question. So we do a lot of work in California. That's where both Brianna and I live too. And Catalyte, the main offices are in California. And one of the benefits that we are seeing in California, that was legislation that was recently passed, was in 2020. Although the pandemic really overshadowed like the excitement of this bill that was passed, was that insurance companies had to provide behavioral health treatment like applied behavior analysis for anybody with a developmental disability. I know that that is unique to California. I do hope that other states will follow suit, because just like with any diagnosis, like I've never heard of a diagnosis that is tied to one specific treatment. So just like ABA is not like a panacea for autism, it can be an effective intervention for different developmental disabilities in a variety of ways. When you look at cognitive behavior therapy, for example, the behavioral strategies that are coming out of CBT are really from that foundational behavior theory that applied behavior analysis leans on. So it can be very effective with other developmental disabilities. I think the thing that is really, really important, that we are hoping to have more communication about, more trainings about, is it can be really effective in various models, which we're going to talk about in a little bit more extensively in a couple of slides, but in a way that fits the individual. So I was speaking briefly about that program Compass B, that's for youth and adults, primarily with autism spectrum disorder, just because at this point, 1 in 22 4-year-olds and 1 in 22 8-year-olds in California have a diagnosis of autism. So we have one of the highest rates in the nation. But Compass B, we have people that have other diagnoses besides autism that it's been effective for. Or when we think about parent training, behavioral parent training strategies that I'm going to teach to a caregiver, they're behavioral parent training strategies that I use myself as a parent, or I would recommend to anybody as a parent to implement. So they are really highly effective. I think what we need to become more creative about is how they're implemented and how we disseminate that information. Great question.
Yeah, I agree. Which kind of leads us into our next area. You started talking about this a little bit, but parent and caregiver involvement. So I know for me personally, when I started in the field, what seems like a lifetime ago, parent caregiver involvement, it was very much, it was part of treatment, part of care, but it was kind of on the outskirts. It was something that you did, but it was kind of secondary to at that time what was more the typical approach with that paraprofessional tiered model, which it still is today, but something that Lindsey and I and Catalyte have been really focusing on is parent and caregiver involvement, and what does that look like, and how do we model that in our programs to really focus on the outcomes like we were talking about just before. So I'm sure when you guys look at this, you know, nothing is going to jump out as surprising to you around the areas that are important when it comes to parent and caregiver involvement. So consistency, like Lindsey was saying, the behavioral strategies that we're focusing on and teaching parents, you don't use it one time and then it works and, you know, miraculously, you don't have to do that again. It's all about the consistency. A lot of the families that we work with, they have, you know, multiple children, and potentially only one of them has autism spectrum disorder. The consistency, the strategies that we're working on with families, they can be implemented for any child. Like Lindsey was saying, you know, she implements them with her kids, I implement them with mine. Generalization and maintenance. So really looking at kind of the thought of if we work with a child to have a skill in one area, can they generalize that across different people, different environments? And can they maintain it over time? If we teach something, they learn it, and then they forget it a week later, it's not meaningful. And it's not meaningful for their life, which is really what we're looking at. We also really want the parent caregiver involvement to be collaborative. Whenever we're working with our clinicians, we're making sure that they are putting parents in the driver's seat. Parents are the absolute expert of their children. They know them better than anyone. So really building that partnership where we as the behavior analysts have these strategies and skills, kind of tools to put in the parents' toolbox. But the parents are helping lead the way and come up with a plan and what the goals are for treatment. Individualization is one of the concepts I think you'll hear any BCBA or any behaviorist talking about. The plan, the treatment, the goals, they need to be individualized to that patient, their family, and their family priorities. This goes to everything from what are the goals that we're working on, but also the language that we're using in treatment. I heard a great example the other day that another BCBA shared where she was talking about she had been working for months and months trying to work on taking a break for a child who's getting really overwhelmed and needed to be able to kind of step away from work. They're teaching a break over and over, and the kid was not getting it. Everyone was getting frustrated. She had a conversation with the dad and was like, I never use the word break. I just tell them to chill out. So they tried that in session and they taught the child how to say, like, I need to chill out. Kid got it. So individualization is not just about the goals. It's about understanding, again, getting that, the parent and caregiver involvement, but also looking at like, what is the culture of that family? What are the priorities? Communication, how do they work together? Empowerment. I think this one goes without saying, like I said, parents, caregivers, they're the expert in their child. And our job as behaviorists is to support them, empower them, fill up that toolbox so that they don't need us anymore. The best day, I think, for any of us who are working in this field is the day a parent says, I think I got this. It's kind of annoying to meet with you. Like, that is exactly what I want to hear. We want parents to feel empowered. We want our clients or our patients, if we're working with them directly, to feel that empowerment, that self-determination of like, yeah, I got this. And then social validity. Whatever we're doing, it needs to be meaningful. It needs to be meaningful to that person, to their life, to their family. Otherwise, why are we doing it? We need to be making sure that what we're doing is improving their well-being. That's something that we are really focused on. All of our clients and our families, we developed a well-being scale that we've normed for the ID, ASD population, because, well, if it doesn't lead to well-being, then why are we doing it, is kind of our philosophy. Everything should be coming back to the quality of life for that person and that family. And so all of those come together into our service offerings, specifically our applied behavior analysis programs. So like Lindsey was saying, we've really focused on kind of expanding the options that families had. A decade ago, 2 decades ago, if you got an ASD diagnosis, you got ABA, you got 3-tier, typically ABA, and it was very kind of cookie cutter. So at Catalyte, we've really focused on this and expanded what offerings do we have, what options do we have for families, because choice is really important. Going back to that empowerment, that self-determination, families, clients really need to understand what the service is that they're receiving and have that buy-in and want that. So we've got a few different ABA programs that we offer. We have parent-led ABA, which is the behaviorist working directly with the parents or caregivers, teaching them the different applied behavior analysis strategies, working with them on implementing that, and then really, like I was saying, like teaching the families those strategies that they can go implement with their child. We also have 3-tier ABA, which is paraprofessional-led ABA. So a paraprofessional is trained to work directly with the client. The behavior analyst supervises that paraprofessional and also works with the parents and caregivers on implementing that typically in their home or in a clinic. Then we have parent training, which a lot of times people ask, well, what's the difference between parent training and parent-led ABA? And really the difference is who the focus of the goals are. So with parent-led ABA, goals and the focus of treatment is on the child. In parent training, the focus is still obviously on the child, but it's on the parent, teaching them different skills and really kind of building their abilities to address whatever areas they need to with their child, whether it be dangerous behavior, challenging behavior, communication. So really focusing on the parent and supporting them. Then we have Ruby, which is not a program that we've developed. That was developed by Dr. Karen Bears and colleagues. It stands for Research Units in Behavior Intervention. And Ruby, it's a manualized parent training, parent coaching model. So it uses behavioral strategies, and the focus of that is on challenging behaviors. It is a shorter program in duration. It's about 12 weeks total. And the parent or caregiver meets directly with a Ruby trained clinician. Excuse me, like I said, it's manualized. So the clinician is running through the curriculum with the family. But again, the goal and the skill set is to teach the family, give them the tools so that then they can continue when the treatment team is gone. And then last we have Compass B or Compass Behavioral. That's the program that Lindsey had mentioned. It's for youth and adult, and the clinician or the behavior analyst is working directly with the youth or adult, the patient themselves. It's a coaching model. It is focusing on social behaviors, executive functioning, and it's very patient goal oriented. So when a patient comes in, we do an assessment with them to understand kind of what are the different areas that Compass B has that we could focus on. And then ultimately they're making the decision. These are teens, these are adults, they know what they want to work on. So, the assessment might show that they have a deficit area in social, let's say. They might say, no, that's okay. I don't want to work on that. I want to focus on something else. So it's very driven by what their goals are. That's also a shorter program in duration, and really effective of getting them those skills and then allowing them to go off and use them in the world and not having to, be tied to a treatment or sessions. Anything add on there? Oh, go ahead.
Yeah. I was gonna say, we could probably talk, do an hour-long talk on each of these specific
Easily.
Areas. Like Ruby, for example, is such an effective parent training manualized model that's all focused on applied behavior analysis. But what Brianna said that's so lovely about it is it's about a 12-week time commitment. But the studies that have been done on Ruby demonstrate its effectiveness time and time and again. So I'm a Ruby certified clinician. I've implemented this with families. I feel like what I have seen happen with this model of intervention is so positive. And we see that translated in these randomized clinical trials, which are so fantastic. And then parent-led ABA, we just had a study published last year that actually compared parent-led ABA to 3-tier ABA. And the results for both treatment groups, whether they received parent-led or 3-tier ABA, were equivalent, except the kids who received parent-led ABA actually did better in the social skills area. So all this to say, there's multiple different ways that applied behavior analysis or procedures of applied behavior analysis can be effectively implemented. And I want to go back to a question that was in the chat about like who this has been effective for, what populations. And somebody had mentioned ADHD. Yes, ADHD, but not in our 3-tier model, right? What we know with ADHD is behavioral parent training is one of the best interventions that could be implemented for ADHD. But all the behavioral parent training methods that are being implemented in that model is based on applied behavior analysis. We also see it with intellectual disability. More specifically, I've worked with kids with Down syndrome, teaching them different skills to help decrease dangerous or disruptive behavior and increase more functional skills, functional communication skills like pointing or simple words, sentences to get what they need. So I have seen it be effective with other developmental disabilities. But I think the important thing, again, going back to what Brianna was saying, is individualizing it to what is needed for them, and not just assuming that the best thing for them is that 3-tier ABA model.
Lindsey, we have a question in the chat about any patients with substance use disorders for these different programs.
Well, I should say this, we don't work with people with substance use disorders. But like this will maybe answer 2 questions at once. We do use motivational interviewing. We train our clinicians in motivational interviewing, which is, I'm sure all of you know, is a very, very effective therapeutic method to help evoke behavioral change. So, that really touches on that top question, do we spend time trying to motivate parents? So we use the motivational interviewing to find like what are things that are most important to them? How can we encourage them and support them in implementing these things? And I bring that up because motivational interviewing was originally developed for people with substance use disorders. So Miller and Rolnick, they developed it in the 80s, 70s, 80s, and then we've kind of carried it forward. So I have never worked with a substance use disorders, but I can imagine like those motivational interviewing principles, those are really based on behavioral principles, can translate pretty well, but that is the extent of my scope and knowledge, so I'll stop there.
Yeah, and then just going back to that question about, do we spend time trying to motivate parents to participate consistently or outside of training time? I think kind of twofold answer to that question. There are always families where it might not be the right fit or the right time, which I think is also really important. Sometimes families start treatment and it's just not the right time for them with whatever is going on in their life. So absolutely, there are times when we, clinicians do struggle with that, I would say. But what I will add is what I've seen consistently time and time again is when parents start working with a clinician and they have their first or second session and they've gotten a couple of those tools that they're implementing, the different ABA strategies, and they see the changes that happen with their child. And we kind of call them the easy wins. They see that change. That's where that buy-in comes from. And, then it's filling up those tools so that they know what to do. So I think there's a lot of different strategies, like Lindsey was saying, around motivational interviewing and getting parents invested and excited about treatment. But typically what I see is once you've got that and once they start it, parents are really invested. They're excited to see the progress and to kind of get that relief, if you will, of, oh, there's something that I can do that is going to improve whatever this area is in my life, whether it's challenging behaviors or, seeing their child able to communicate or socialize. That within itself is really motivating for families. All right, let's see, Lindsay, do you want to close
Yeah,
this
so
out?
we'll have a few minutes for any more Q&A, but like our closing thoughts are ABA interventions can be very effective. They're evidence-based interventions, but it like one size doesn't fit all. It's not going to be effective for every single autistic person, and it's not going to be like in every single situation. So individualizing the care is so important. And we just really emphasize one size doesn't fit all, really trying to find like what is going to be most effective for the family or the patient, you know, whatever the makeup of that family is, whoever's in the close-knit community for the patient. So with that, are there any other questions that Brianna and I can answer?
Well, do you know much about Luke's Law? Monica found it. It says that insurance has to cover ABA for treatment
Yeah.
for autism.
Yes, yes.
That's
So
good.
that was passed in, I think, 2016 in Hawaii.
I don't know. Monica Borge found it.
Yeah,
Yes,
2016, yeah. Yeah, so in 2016, that law was passed saying that for autism spectrum disorder, ABA had to be a covered intervention in the state of Hawaii. The hope is that more legislation will pass where it's not just the ASD diagnoses, but it's any developmental disability can receive behavioral health treatment covered by insurance.
Which is great because the Felix decree, when it went away, made it hard to get treatment sometimes.
Mm.
Yeah. And Colleen asked, and you may have addressed this, but it's an interesting question about whether you have to motivate the parents to participate or practice outside of training time, when it sounds like, well, I don't know, it sounds successful if the parents do. So maybe the question is, how do you motivate them to really participate when they're there, when the kids are there and at home?
Yeah.
That sounds like what success.
Yeah,
Success.
absolutely. And I think Brianna touched on this a bit, but it's when parents like have that initial win, usually I won't say this is every single time, but usually it's around a communication thing. When they've developed a communication strategy with their child that is really effective, and we get that initial buy-in, it's like, wow. And once you have that buy-in, parents are sold. We actually have our Catalyte conference this week. And we're lucky enough to have a parent who's going to be on one of our panels talking. Sorry.
Sorry, we've got.
Okay, talking about you know, she has 2 autistic children, and she went into parent mediated ABA because she was like, I don't want to wait for paraprofessionals, or I get nervous that the paraprofessionals are just going to quit, because there's a high rate of turnover in our field for paraprofessionals. So she started implementing parent mediated ABA or parent led ABA, and it was so highly effective, right? And those are the stories we hear over and over and over again from parents and from clinicians. To be honest, when we first started looking at parent mediated care in 2017, I mean, I was skeptical. I don't know if you were skeptical, Brianna, but I was skeptical because that wasn't how I was originally trained. But then when I started diving into the literature, it was like, oh my gosh, there's so much literature supporting this model of care. We started training our clinicians on implementing it. And at first, our clinicians were nervous, right? Because they weren't originally trained in this. And it's the same exact thing. We give the clinician the skills on how to engage with parents, which is so, so important in our work. And they have their first wins as clinicians with parents. They're like, oh my gosh, parents can do these things because we can implement them all the time. It's just about consistency, which I think is also good when you're not always consistent as a parent, because that's more real life than if you're 100% consistent. So is the same paraprofessional consistently working with the family? No, it's not that. So the question is the same paraprofessional consistently working with the family most of the time? And unfortunately, I think it's been like this, Brianna might know better than me, for about at least 8 years, I would guess, where it is so hard to keep paraprofessionals in the field. So families usually have anywhere from 2 to 5 paraprofessionals coming into the home. And then we have a very, very high turnover rate. I think it's about 3 to 6 months And that's not just our organization, like that's kind of more writ large. So that makes it very, very, very difficult on the child, particularly if you like take autism spectrum disorder, their like core challenges are with social engagement. It's difficult on the child, it's difficult on the family to have like this rotating door of people coming into your home.
And is it 20 hours a week? I mean, it seems like that's what's shown is so beneficial, or is it the parents?
Oh, with
doing-
parents, when parents do it,
Yeah.
we don't like they're actually, that's a great question because this is a question a lot of people have asked. There hasn't been any study that I have seen, and we haven't done the study that has made parents or asked parents report out on the number of hours they work with their child. So that would be interesting. That being said, as parents and caregivers, we are with our children most of the time. And if we're taught these like pretty basic behavioral strategies, you can implement them in the most natural moments of the individual's life. So we really focus on, with our parents and caregivers, implementing these skills at the most appropriate times in the child's life, like during bathing routines, during dinner routines, during transitions between and from school. So really capitalizing on those like really good moments where we can teach a new skill.
Because you did say it was best to have it like 20 hours a week, the treatment, right?
No, so what we see diminishing returns over 20 hours a week.
But up to?
We are seeing like definitely no more than 15 hours per week. And then there's new research coming out by Vanderbilt and the DoD that might even be showing around 8 to 10 hours per week.
Okay.
But we'll have to wait for that study to be published.
All right.
I was going to say really quick too, our research study that's currently under review, we also looked at hours and we found no difference in treatment outcomes between 8 hours per week and 23 hours per week.
Okay, so there's a sweet spot.
Yeah.
All right. Thanks, Summer.
Thank you. Bye, everyone.